Innovations in surveillance protocols in Barrett's esophagus. As we know, Barrett's esophagus is a complication of chronic reflux disease and is a known risk factor for esophageal adenocarcinoma. Surveillance endoscopy is recommended every 3 to 5 years for those patients diagnosed with Barrett's esophagus to evaluate for any progression to dysplasia or cancer. We will first review the foundation of a surveillance examination in Barrett's esophagus. I use the 5 L's to summarize the quality measures we should be doing and documenting in a high-quality surveillance protocol. These are landmarks, length, look carefully, lesions, and levels. The first L is landmarks. We should identify and document the location of the diaphragmatic impression, the gastroesophageal junction, and the squamocolumnar junction. Displacement of either or both the squamocolumnar junction and gastroesophageal junction allow us to document and describe states of hiatal hernia, Barrett's esophagus, or Barrett's segment in the setting of a hiatal hernia. The diagnosis of Barrett's esophagus requires the endoscopic criteria, which is the salmon-colored lining in the tubular esophagus, and the histologic criteria, or the specialized intestinal metaplasia with columnar-lined epithelium and goblet cells. When we suspect Barrett's esophagus during an endoscopy, we should perform at least 8 biopsies to reduce sampling error. The second L is length. We know that longer segments, those that are 3 centimeters or greater, have a greater risk of progression to cancer compared to those that are short segment, those that are 1 centimeter or greater but less than 3 centimeters. The PROG classification system is a validated method to measure and document length. We do this by starting with the top of the gastric folds and measuring to the circumferential extent and then the maximal extent of the contiguous Barrett's. We then denote this classification with the C and M letter. The example here would show the top of the gastric folds at 35, the circumferential extent at 33, and the maximal extent at 30, and therefore we denote this segment as a C2 M5 Barrett's esophagus. There is some controversy as to what happens when we encounter an irregular Z-line. When we see variability of less than 1 centimeter at the squamocolumnar junction and biopsy this, it is possible we might pick up intestinal metaplasia, but these findings may reflect gastric mucosal changes rather than actually Barrett's esophagus, and therefore may not carry the same risk of esophageal cancer. It is recommended that we avoid biopsy of an irregular Z-line with less than 1 centimeter of variability without any evidence of mucosal irregularity. The third L is to look. We should look carefully and try and use the best scope that we have as our main tool. We now have high-resolution endoscopes that provide 800,000 to 1 million pixels to allow for greater detail. Also, endoscopic techniques, such as irrigation and mucolytics if needed, help expose surface area. Tip deflection and the use of a soft distal attachment cap can help examine the mucosa en face and expose areas between folds like at the GE junction. The part of the Barrett's examination that's also important is a careful retroflexed examination to evaluate the GE junction and the cardia. Insufflation and suction are also useful techniques during the examination to appreciate any subtle lesions that we might find within the wall of the esophagus. It is known that longer inspection times are associated with higher rates of detection. It is also important to improve our recognition skills so that we recognize subtle flat lesions. If we only look for protruding lesions as we look down the lumen of the esophagus, we might miss more subtle lesions. For example, in this image on the second photo, we can see color variance and mucosal irregularity in this area. With tip deflection and the use of the soft distal cap, we can see this area of mucosal irregularity, and this area was diagnosed as high-grade dysplasia. We should familiarize ourselves with regular appearing Barrett's mucosa, where we see ridge, villus, and cerebriform patterns. Contrast that to areas of loss or distortion of patterns where we find suspicious areas of Barrett's mucosa, such as the bottom panel. The fourth L is lesions. When we do encounter a visible lesion, it is important we describe it. A recommended classification system is the Paris classification system to denote polypoid and sessile lesions, relatively flat lesions, or excavated lesions. We know that those lesions that are protruding or excavated are at higher risk for carrying submucosal invasive disease than those lesions that are slightly raised or completely flat. The fifth L is levels, or biopsy at multiple levels with the Seattle protocol to evaluate for occult neoplasia or subtle disease. We do this by first targeting all visible lesions and biopsying those separately, and then performing 4-quadrant random biopsies every 1 to 2 centimeters, specifically every 1 centimeter if there's a history of dysplasia. Limitations to this protocol include sampling error and poor adherence, which is associated with increased risk of missed neoplasia. Longer segments are associated with poor adherence. Other things that we can do to improve our surveillance in Barrett's esophagus include improved targeting and tissue acquisition. Endoscopic mucosal resection is required for visible lesions in the setting of dysplasia to rule out cancer. EMR is more accurate than biopsies or EUS and can change the diagnosis in up to half the cases. There is less interobserver variability among pathologists with EMR compared to biopsy forceps specimens for the diagnosis of neoplasia. While EUS is appropriate for nodal staging, it is inadequate for early T staging for superficial neoplasia. Wide area transepithelial sampling, or WATS, is an abrasive brush that can be used during an endoscopic procedure to collect cells throughout the Barrett segment. The cells are then placed on a slide and stained, and the slides are scanned into a computer which provides 3D image constructs and analyzed with a computer neural network. These suspicious areas then identified by the computer are then confirmed by a pathologist for diagnosis. Multi-center trials, including both community-based studies as well as prospective trials, demonstrated an increased yield of detection of dysplasia by WATS compared to forceps biopsies alone. While there is not consensus on what the actionable item is for a WATS positive and a forceps biopsy negative situation, this tool provides a means to sample large areas of the esophagus to identify who may harbor signs of neoplastic transformation that may then prompt a more rigorous evaluation or tailored next step. This technique can be utilized in addition to the Seattle protocol to improve detection of disease during surveillance endoscopy for Barrett's esophagus. Chromoendoscopy is a technique where an agent is sprayed onto the mucosal lining, and then an enhanced visualization of the mucosa allows for targeting biopsies or resections. Acetic acid is a contrast agent which has met ASGE thresholds for surveillance for the detection of dysplasia and can be utilized for surveillance protocol. This agent essentially is sprayed onto the lining and creates a whitish effect of the mucosa. You can see here in this picture on the left, the enhanced mucosal pattern on the left side is more regular appearing, whereas the right side, it looks like there's a distortion or loss of pit pattern. This distorted area was diagnosed as high-grade dysplasia. Digital chromoendoscopy is widely available and easy to use with a push of a button. Narrowband imaging is the most studied and is a filtered blue light. It enhances the mucosal pattern and vascular pattern. Other post-processing platforms are also available on other systems. NBI also has met the ASGE thresholds for incorporation into a Barrett's examination in addition to the Seattle protocol biopsies. We can identify areas of suspicion that we'd want to target by using the Bing criteria. This is looking at the mucosal patterns and the vascular patterns and simply classifying them as regular, irregular. Those areas that are irregular mucosal patterns or irregular vascular patterns can be targeted for tissue acquisition, and then the remainder of the segment can be biopsied with Seattle protocol biopsies. In summary, the foundation of detection is based on high-resolution endoscopy, detailed assessment, and improved recognition. Visible lesions in the setting of dysplasia should be diagnosed with endoscopic mucosal resection. Wide area sampling and targeted biopsy techniques with chromoendoscopy or virtual chromoendoscopy, in addition to the Seattle protocol, can improve detection of dysplasia.